You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. In the first part of our series on clinical reasoning, we started with deductive reasoning as our reference point, going from a large list of possibilities to a final likely diagnosis. Later, in the second part, we contrasted this with inductive reasoning, when we start with a specific finding or complaint, and we go to our own list of dangerous diagnoses that we must rule out, regardless of how likely or unlikely they are. Today, in the last installment of this 3-part series, we'll bring it all together and talk about the mode that we mostly work in, that of abductive reasoning. In our favorite intergalactic series, Star Trek, the 3 main characters, Spock, Bones, and Kirk, serve as a good example of the different philosophies or perspectives that we can use when we meet a clinical challenge. Spock, the half-human, half-Vulcan first officer, is very knowledgeable. He's disciplined. He's patient and methodical. He uses deductive reasoning regularly. Spock considers countless possibilities and probabilities and works through them methodically to arrive at the most probable. His calculated approach can make the difference in a complicated matter. McCoy, or Bones, the ship's doctor, ironically works mostly in inductive mode. There are some things that he knows and can do, and the rest he responds with, "I'm a doctor, not a physicist," or whatever. Bones has a short list of things that he owns, that he can attest to, that he can do something about, and that's it. He's there for you when you need him. Kirk, interestingly, is who we end up being mostly in the ED. Kirk takes a messed up situation with barely enough information to function and lots of uncertainty, and he makes his best educated decision or guess about what's going on and what should be done. For all of his foibles, he deserves the title of Honorary MD, which, of course, stands for Make a Decision. Let's dive deeper into what abductive reasoning is, what it can do for us, and when we should or shouldn't use it. Abductive reasoning comes from abducere. It means to lead away from, to take something somewhere else. Abductive reasoning is starting with an incomplete set of observations and taking it to the most likely possible explanation. It's what we do all day. Better than a random guess? Not as great as a 2-week admission with a battery of tests. Abductive reasoning is pragmatic, reasonable, cautious, and necessary. Now, deductive reasoning is hard to argue with. It can come to a powerful conclusion, but deductive reasoning is just not very practical. Deductive reasoning feeds off of massive quantities of data. Inductive reasoning is efficient for its own agenda, but it can otherwise be inconclusive and sometimes frustrating. Abductive reasoning deals head-on with the limitations to the situation and does the best it can with what it has, aka it's most of emergency medicine. Of course, philosophy and life are much more complicated than that. We work in multiple modes, and we switch back and forth constantly, often without realizing it. My point here is that it's important to know what mode you're currently thinking in so that you can be aware of its limitations or even its advantages. It may help to stay stalwart in your approach, or it may help you to rethink the method that you're using. As we mentioned, we're using all three all of the time, but let's do a little thought experiment to illustrate when one may be more helpful than the other. Joni is a 5-year-old girl with the chief complaint of cough. Now, before you see her, you could come to different conclusions about what she has. Deductive reasoning would have you ordering a chest x-ray on her before you even see her, maybe some labs, always needing to feed the beast of a long pre-programmed list and thirst for more data. Starting from a long list of hypotheticals to the specific observations you find. Inductive reasoning would have you walk in, see her normal vital signs, and discharge her post-haste, quickly deciding that this is not pneumonia or pneumothorax. It's nothing that you own. Inductive reasoning has you start from certain observations to a certain list of dangerous hypotheticals. Abductive reasoning would not have you do either of those things. And so we begin. As you enter the room, Mother is frustrated by the wait. She's short with you. She seems very, very concerned about this preschooler who seems very, very well and pretty bored. Also, someone who hasn't coughed once while you've been there. Your deductive reasoning would have you spend 45 minutes on a history, order a slew of labs to figure out just why she's coughed every day of her life, or maybe just every other day, or maybe that was a few times each year, we're not sure, but many of these studies would not be back in the time frame allotted, and meanwhile, the septic patient is tanking in the other room. The patient with chest pain has dynamic EKG changes. Someone else is seizing, and you've had to pee for the past 2 hours, and the waiting room is blowing up. Your inductive reasoning would start with the chief complaint of cough. And then you run through the list of dangerous diagnoses. Surprise, surprise, you find no life threat. You're brief with them, you're ready to get them out of there, and you rush them out, and you probably generate a return visit or more. Your abductive reasoning would get more clues, whatever is available in the here and now. Oh, this cough has been going on for a week. Okay. It seemed to come about just when school started. Okay. You find out quickly, because you asked, what else is going on. It turns out the cough is just the tip of the iceberg. The mother is concerned because the father does not want to vaccinate. It gets deeper. When you ask and probe for more info, the mother now really wants to get out of there. She's scared. Why? There seems to be a lot of psychosocial stressors going on in that room, and you find out that the great-aunt had just died from lung cancer, and that this is all the family can think about. You can generate all kinds of theories about what's going on, but what do we do? We can use deductive reasoning and consider trying to get to a definitive, exhaustive search for the cause, but ain't nobody got time for that, and it's just not needed. We can use inductive reasoning and think about worse first. It's not any of those, but have we given the family what they need? After those two thought experiments, we toggle to our abductive mode of clinical reasoning. It's a cough, and they're here because they're scared. Is there a send-out lab that can confirm the fear and anxiety titers in the family? Is there a comprehensive cough panel that you can send? No. There's a doctor who cares and pays attention. He remains aware of his own biases. what mode of thinking he's using, and he does his best to choose the right reasoning for the right situation. In this case, you could send a battery of tests, deductive, but the downside could be causing lots of fear, trepidation, and unnecessary cost and potential iatrogenia. Deductive reasoning here could be counterproductive. Now, you could take the symptom and make sure it's not anything dangerous, inductive, and stop there. Inductive reasoning here, it would get the job done, but you wouldn't have helped them with what they came in here for, what they needed from you right here and right now. Abductive reasoning wins the day in this particular case. Can you prove any of it beyond a reasonable doubt? Well, maybe not, but you can document your reasonableness, your concern, your thought process, and your plan for follow-up. You balance what the patient needs with his safety. Now, I'm sure at this point in our discussion, you can adjust the presentation in favor of one method of clinical reasoning or the other. Maybe our friend Joni here with a cough is a returning traveler. Okay, deduction and a battery of tests, here we come. Maybe Joni has acute onset shortness of breath with her cough. Breath sounds, are they completely bilaterally equal? Chest x-ray confirms spontaneous pneumothorax. So you can feel free to cancel the deductive battery of tests, including tuberculosis acid-fast bacillus and pertussis PCR. In this version of the case, induction got you where you needed to be. Or maybe you just needed to balance out what the patient needed from you and what clinical reasoning method, deductive, inductive, or abductive, that she needed you to use. This concludes the 3-part series of an introduction into clinical reasoning. Just some short plays to get you further down the field. Please let me know what you think, and as always, what I can do to help us all take better care of our patients. Thank you for listening. Until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.